All right, well, thank you everyone for joining us today. I'm going to go ahead and give some introductions. We're still wrestling through a few technical difficulties to make sure we have everybody connected here, but I really appreciate how we've had everyone join. So, welcome everyone to our webinar discussion today in our series related to COVID-19 and global health. My name is Dr. Rachel Vreeman. I am a pediatrician and I specialize in the long-term care of children and adolescents who are growing up with HIV in sub-Saharan Africa. I'm also the chair of the Department of Global Health at Mount Sinai School of Medicine and the director of the Arnhold Institute for Global Health, which is the host for this webinar series. And we're incredibly excited today to take some time to really talk about and dig into an issue that is very close to my heart. Thinking about global and local maternal health disparities, and with a particular focus on how maternal health disparities, this critical issue for health inequity in particular, has been impacted or may continue to be impacted by the COVID-19 pandemic. We have an incredible panel of experts who have been willing to join us today. Hopefully our technical limitations will not prevent any of that joining from taking place. I'm going to go ahead and move through introductions, and maybe we'll check in after I introduce each person and see if we have everything connected for them as we go. So let me start with Dr. Savitri Sapkota, who I can see and I think I will be able to hear as well because she's been working most consistently. Dr. Sapkota is the Director of Implementation Research for Naya Health Nepal, which is a nonprofit healthcare organization that works closely with the government of Nepal to provide health services. We're incredibly grateful to have her joining us from Kathmandu, Nepal today to be part of this discussion. Dr. Sapkota is also an adjunct faculty member at the Arnhold Institute for Global Health with us in New York City. She's been actively involved in the local COVID-19 response in Nepal, together with the team at Naya Health Nepal. And she brings to that position more than 20 years of experience in research, training, and project management related to reproductive, maternal, neonatal, and child health. And her experience has been across numerous countries, not only Nepal, but Afghanistan, Bangladesh, Cambodia, Laos, Myanmar, and Singapore. She is passionate about creating a culture of evidence-based decision-making within Naya Health. And before joining this team, she worked as a regional research advisor for the Marie Stopes International Organization in the Asia and Asia Pacific region, and has also supported multi-center and multi-country clinical drug trials for the Institute of Mental Health in Singapore. Dr. Sapkota has a degree in nursing as well as a degree in public health and a PhD in health sciences. So thank you so much for joining us today, Dr. Sapkota. Shall we check in and make sure we can hear you? I see you there.
Yeah, thank you, Rachel, for having me in the webinar today, and thank you.
All right, terrific. So we'll hear more from you in just a moment. We also are joined by Dr. Wendy Wilcox. Dr. Wilcox is the chair of the Department of Obstetrics and Gynecology at NYC's Health and Hospital King County location. She is an associate professor of clinical obstetrics and gynecology at SUNY Downstate Medical Center and St. George's University. She has practiced obstetrics and gynecology for over 20 years. Dr. Wilcox is the co-chair of the New York State Task Force on Maternal Mortality and Disparate Racial Outcomes. She is also a steering committee member for the American College of Obstetrics and Gynecology's district-wide Safe Motherhood Initiative. And she has really been a leader in the discussion about equitable maternal care in New York. We're incredibly privileged to have her with us today. Dr. Wilcox graduated from Brown University with her bachelor's in bioethics. She received her medical degree from SUNY Upstate Medical Center in Syracuse, New York. She has a master's of public health from Columbia University, and she's board certified by the American Board of Obstetricians and Gynecologists. Thank you so much for joining us today, Dr. Wilcox. Let's just check in with a hello to hopefully hear you as well as see you. Oh, great, I hear you.
Now?
Yes, Excellent.
Wonderful. I'm sorry. On my desktop, I don't have a microphone attached to my computer, so I always dial in, and I didn't realize that in the link I didn't have the phone number. So thank you for sending it, and I'm really honored to be here today. Thank you for inviting me.
No problem. Thank you. It is truly our honor, and we appreciate the time that you're taking with us today. So very glad we have you all connected. And then we also have with us today Dr. Teresa Janovich. Dr. Janovich is a perinatal epidemiologist who focuses on health disparities and social determinants of population health. Her research examines why social exposures such as neighborhood context, racial discrimination, immigration, and stress influence perinatal and reproductive health outcomes and the role of the quality of healthcare in these relationships. She uses what's called a mixed methods approach for her research, which means that she combines large administrative data sets to provide a broad real-world population health perspective, while also engaging in community-based qualitative work to try to give voice to vulnerable women within the communities in which she's examining these hypotheses. Her research portfolio includes projects on the role of hospital care and the social determinants of maternal and neonatal morbidity, healthcare discrimination and maternal health, disparities in the long-term health after women experience gestational diabetes, and the influence of healthcare policy on immigrant maternal health as well. So we really are, as I said, truly delighted to have the three of you with us for this discussion today. We hope to think both from a local standpoint, for those of us who are sitting in New York and thinking about New York quite actively as well as locally considering the United States and what that means, but also to have the global perspective with at least one voice to help us have a lens into how we think about maternal health globally as well with Dr. Sepkoda. So I guess starting, with where we are at this moment right now, sadly in New York City, Black women are still nearly 8 times more likely to die from pregnancy-related causes than white women. And when we think about Latina women, especially Puerto Ricans, we also see much higher rates of life-threatening complications during childbirth. Among the many stories that I think nationally and globally we are grappling with and what they mean for the much bigger picture for health inequities right now. A recent story that brings this to mind for me is the one of Amber Rose Isaac, who recently died during childbirth in the Bronx in April. And anecdotally, as we consider these really tragic stories that amplify this, we of course suspect that COVID-19 in this current pandemic may be adding even more challenges onto equitable access to maternity care than the additional disparities and challenges that we're so concerned about as well. And I hope that as we talk today, we can really have maybe a better picture of both what we know and what we are suspecting or what we really want to consider and challenge and think about related to these pandemics on top of each other and on top of each other, pandemics of racism, pandemic of COVID-19, and as we think about in our very particular healthcare systems, what impacts that has on maternal health particularly. So I'm going to ask each of you first to take a little time from your respective vantage points as clinicians and researchers who are focused on this area of maternal and child health to share a bit about the work that you do so we can understand that. With that, please feel free to contextualize related to the national picture, the regional picture, and locally what is happening in maternal health, but then also with an idea of what you're starting to see related to COVID-19, its impact and how that's shaping disparities. And we'll keep digging into this, but I'd like to hear from each of you about the work that you're doing and then a bit about how COVID is starting to shape those challenges as well. Let's go ahead and start with, with Dr. Wilcox, if you don't mind. We'll start to dig into a New York perspective and then we'll move to the Nepal perspective after that.
Well, thank you so much again for inviting me and for asking that question. So for a while, we've known that Black non-Hispanic women in New York City and New York State, as well as in the United States, have much worse outcomes when it comes to pregnancy, whether it's maternal outcomes and or fetal outcomes, to be quite frank. And so having worked closely with the New York City Department of Health for a while, and in my role as an OBGYN and now in a role of departmental leadership as well as system-wide leadership for health and hospitals, I've had to think just quite concretely about how do we help our mothers during this time of increased stress. I will say that with COVID, it has put a much wider lens on the discussion. So previously when we were talking about this, the discussion always centered around providers of care, as well as the patients and providers. What can you do to exacerbate disparities and help your patients? And I'm not in any way saying that our responsibility is not there, but I think in recent events with COVID and with some of the other political things that are going on now, we see that really the entire system is broken for Black people, not just women, and other people of color and other people who are economically challenged in the United States. And so my hope is that that actually helps the discussion and doesn't hurt it. I think that our patients during this time have been extremely stressed. Some of the emotional insecurity that they may have felt about coming into a healthcare system before and having a baby in a traditional hospital setting has been exacerbated during this time. As a provider, putting on the my other hat, I think we're more anxious too for the patients, as well as not just when the patient is there in front of you, but knowing how difficult it can be to navigate some of our systems and trying to think, as I said, very concretely about how do we make the system work for the patient. And so I actually think some very good things are going to come out of this here at Kings County as well as across the system. I'm sure you heard how televisits have now replaced some visits in prenatal care. Some people have thought that might pose a problem for many of our patients. I will say that for most of our patients that seems to be okay, but what you want to make sure is that they don't miss any episodes of care. So lab work, testing, fetal testing, ultrasounds, et cetera. And how do you keep the communication going? And I'm actually very heartened to know that we are actually adding layers on top of what would be our normal system, layers in terms of extra social work or patient navigators or making sure that we just give that little extra call when patients are discharged, following up post-discharge. And my hope is that when we come out the other end, that we will actually have an improved system. I'll stop there.
And now I was muted. Dr. Yanovic, I'd love to hear from you as we continue with thinking about the New York perspective, but especially describing a bit of the work that you do and thoughts about how COVID-19 may be exacerbating some of the disparities for maternal health and child health in this.
First of all, thanks for having me today. I'm thrilled to be part of this esteemed panel, and Dr. Wilcox just set the stage with a sort of great message of hope out of this crisis. So in our research, we've looked at structural racism as a fundamental cause of some of the disparities we see in severe maternal morbidity. So one manifestation in New York City of historical processes of structural racism is extreme polarization by neighborhood of wealth, as well as the distribution of racial population. And so we looked at this in association with severe maternal morbidity and found that poor Black neighborhoods, women who live in poor Black neighborhoods were twice as likely to have a severe complication during childbirth as women in wealthy white neighborhoods. And this was due about in half in part to their health kind of going into childbirth. So whether it's a chronic disease or a complication that emerges during pregnancy, like such as preeclampsia. But then importantly, a third was due to the hospital they delivered at. And I think what's most striking is that this impact was really among Black and Latino women. So for Black or Latino women, if you lived in a poor Black neighborhood compared to women from the same background in wealthier neighborhoods, we're at increased risk. And I think this is part of what could be happening or that has the potential to exacerbate disparities during the coronavirus epidemic, because this is showing that beyond sort of your individual health risk, there's sort of structural processes and access to resources that put you at higher risk of a poorer outcome.
Sure, thank you.
Mm-hmm.
And Dr. Sapkota, so turning to you and from a perspective in Nepal, we'd love to hear your viewpoint on some of these clinical and structural challenges as well.
Thank you so much for inviting me today. I think to this audience, I'm not sure how familiar you are in terms of maternal and child health program in Nepal. So maybe before I jump into that one, talking about the challenges in structural systems, then maybe I think I feel it's important to understand the program first. So like in many other countries, Safe Motherhood Program, essential newborn care, care of sick neonates and children, immunization, nutrition, these programs are central to maternal and child health programs. For the government, it is very important for them to ensure that women receive antenatal care on specified months as per national protocol. They receive birth preparedness, it's important for them to come to the health facilities to give childbirth, or if they prefer to have it at home, it's making sure they're assisted by skilled birth attendants. And after childbirth, postnatal care is there for them to support. These are the key components of Safe Motherhood Program, but in order, there are so many system level challenges and there are so many barriers in terms of delays. Therefore, under this Safe Motherhood Program at national level, women are provided with free care during childbirth in public health institutions. Various incentives, not only to women for institutional delivery, but also to skilled birth attendants and health facility per se has been provided. Despite this long-standing and longitudinal efforts of the government to promote safer pregnancy and childbirth, there are still a lot of gaps in care delivery. especially during postnatal period and for newborn care, and also serving to marginalized and vulnerable groups. My organization, like Nyaya Health Nepal, like where I'm working, we are kind of trying to in some way address those kind of the challenges, the gaps in care delivery, especially with the model that we came up with, which is called integrated healthcare. We're trying to show, like, kind of address some of those issues. We are running program in 2 districts. One of them is very, very remote in far western province of the country. I can't even imagine, like, the public transportation is very infrequent, unreliable in there. Pregnant woman and mother carrying their children walk uphill and downhill for a number of hours just to reach the health facility. And even the reach to the health facility, there are a lot of challenges for them in terms of receiving quality health care, the way they've been treated, like, especially for marginalized and vulnerable groups. So what we are trying to do is kind of trying to connect health facility with the community, so that some of the basic kind of follow-up care and then the counseling program we can carry out in the community level. So besides, like, providing facility level care around basic and comprehensive obstetric and newborn care under the umbrella of National Safe Motherhood Program, we have like, child health services that includes immunization, nutrition screening, treatment of childhood illness, among others, at the facility. But we are more focusing on a community level in terms of addressing some of the structural challenges. Where we have this new model. We have, such an amazing locally trained, paid and supervised cadre of community health workers who visit every single household and provide pre-pregnancy care, pregnancy surveillance. They do provide ANC counseling. They do talk about birth preparation. They do conduct and hold group antenatal care sessions, and also kind of like, conduct active and passive case identification and referral in terms of childcare. The government has this integrated, community-based integrated management of neonatal and childhood illness program that has not been effectively run in other areas, but through our community health workers, we are trying to implement it in a way that that's kind of like, the actual implementation and impact is seen in the community. We do focus for children under 2 years of age. So that's, I think, I'm not sure, like, should I go beyond? I'm going to stop here and then maybe come back later.
Yeah, and we'll come back and talk a little bit more about maybe the COVID pandemic impact and what's in particular what's been happening in Nepal broadly. So let me return to Dr. Wilcox for a few minutes. So Dr. Wilcox, in your role, as we've talked about, really as a leader in obstetrical and gynecologic care across a public health system, and also, as a leader and co-chair for the New York State Task Force on this. Perhaps you could tell us a bit more about specific ways that you've been seeing COVID-19 exacerbating the disparities in maternal child health care, and then, but along with that, the types of programmatic or health systems changes that are trying to address some of those issues as well. I know you touched on some of these, but maybe to dig in a little more in terms of, what you're seeing both in the pandemic and also responses to try to address that.
Thank you. Thanks again for asking me. And I realized that I didn't explain about New York City Health and Hospitals. So we're 11 acute care hospitals in the public sector, along with long-term care facilities and other outpatient facilities. New York City Health and Hospitals is the largest public hospital system in the United States. 11 of our facilities do have labor and delivery units in obstetrics and gynecology. And so prior to COVID, a lot of our work was on standardizing care and addressing the top 3 causes of maternal morbidity. some of the ways which we were doing that were to spread in situ simulation drills, and those drills were targeted at the top 3 causes of maternal mortality in New York City, which is hemorrhage, OB life support, which was really how to deal with cardiac arrest in a pregnant patient and save a life. And the third one was to address really severe hypertension and how to mitigate that quickly so that the life of the mother isn't in danger. In addition to that, we're building maternal medical homes, and so to speak a little bit of what I mentioned earlier in terms of having extra layering for patients so that we help them navigate through our sometimes complex systems, and also can have them have a live person that they can pretty much reach out to at any time and to give consistency. We were working very closely with New York City Department of Health to institute some of their programs, along with other programs in other hospitals in New York City. So this wasn't targeted just at New York City Health and Hospitals, but it was really for all New York hospitals to look at implementing quality improvement programs and embedding them in the departments, and also trying to help spread doula care. So a lot of that work was going on. We had our directive from City Hall, and for more than a year, those programs we were working very hard to implement those. And then COVID happened, and we had to hit a long pause. But it was interesting because it definitely gave us a better lens to actually see what was going on. And so earlier when I mentioned some of the emotional insecurity, and this wasn't just for our patients, this is for Black and brown patients, this was for pregnant patients all over. COVID really scared women and really altered the view of birth that many people had, their birthing plans. And what really gave a lot of people pause and anxiety was when we restricted visitation. So for a very short time, there were some women in New York City who had to deliver without a partner and without anyone by their side. And unfortunately, that was kind of all over the city. We actually, in our hospitals, never went to that. We pretty much stayed with allowing one support person. So, I think our patients did benefit from that, but, word of mouth travels quickly, and people weren't quite sure where to get their information from. People were afraid to come out of their houses. We always have to be concerned about women who are either in the shelter system or in other areas. So 2 of the largest hit areas were Co-op City in the Bronx and Starrett City in Brooklyn. And so, just rows and rows of buildings upon buildings upon buildings, and it really spread throughout families, COVID did. So women were afraid to spread it to older family members within their household, their children, and there was a lot of emotion tied up in this. And so I think people were just genuinely very scared. A colleague of mine on another phone call with New York State recently described, this is a different hospital than mine, but described how a patient came in for admission and then actually left because while there for a short period of time, she figured out what the codes meant that were being called overhead every few minutes, and that meant having to address, and even though it didn't affect the labor and delivery setting, it was in her area. So, I always try to be optimistic in that regard. I always try to think of the hospital as larger than just the patient and her provider. And so to me, that's an opportunity to make sure that if and when, God forbid, there's another wave and we have to be cognizant of we have to be cognizant of our environment on labor and delivery, even if it's not visible. What's the ambient environment? Maybe we should turn the speakers down, because certainly the OBGYNs aren't running to codes, right? But we want to make sure our patients aren't exposed to that. And, you know, the information void was huge. And on a few calls, you know, with the obstetricians and gynecologists through ACOS, also with New York State, the question was, how do we get reliable information to our patients? And sometimes that was difficult because I'm not even sure we had reliable information. You'd go on the internet and you'd look for our usual leaders, and the information would change sometimes within a couple of hours, certainly within a couple of days, and what you were learning in the beginning of 1 week wasn't the same. And so it was hard to then translate that information to the patients. And so, you know, those are some of the ways which I saw that piece of it exacerbated. I think we're in a good space now. I think the information is consistent. It's being echoed, you know, the same work that's being put out by New York State. New York City is emulating ACOS. You know, we're getting all of our stakeholders on the same page in terms of what advice do we give to pregnant women. We've realized pregnant women should not deliver alone. And so, you know, we have guidance now to allow the support person and or a doula if they so wish. And I think we all have to come back to our own facilities and really just look at the lay of the land and say, is this still a welcoming environment? Even if everyone is wearing tons of PPE and you can't really see people's faces, et cetera. And so, you know, that's a challenge, and we're going to continue to work on that.
Yeah, you know, and I think you bring up, you know, a lot of points that we wrestle with in the healthcare system under any circumstance in terms of how do we create welcoming environments, how do we communicate effectively with the communities that we're serving about, you know, what they need to, you know, what's most helpful for them to promote their health or prevent risks in these ways, how we, you know, recognize what anxieties and fears people have and how we can shape that. And then this pandemic has just magnified all of those challenges, and especially because, you know, we as physicians or healthcare leaders or researchers, like we too have not known as quickly as we've wanted, or in some ways still don't know, you know, precisely what, you know, the best strategy is with this new virus that you know, that we're learning more about every day in those ways. So figuring out these things like how best to support pregnant women during delivery, while also, you know, maintaining the right level of infection prevention around them so we can try to keep them and their families and their babies safe, and yet at the same time not make other things so much more difficult as well, and also the communication challenge that arises with that, which, I mean, obviously, you know, the hospital system is really taking a lot of steps to try to address this, but it just speaks to what major challenges these are that I would say humbly, like, we don't do a great job at this anyway, or like there's always more we can learn in this field. And then it brings all of that into more clarity that way as well. Let's turn back. Actually, I should say for a moment, because I forgot to say it at the beginning, we will have some time at the end of the hour to take a few questions from those who are listening with us and participating today. If you have a question that you would like for us to try to address, there's a Q&A box that should be available at the bottom of your screen, and at any time, feel free to type in a question there, and we'll get to at least a few of those towards the end of the hour. We'll shift in, but know that you're welcome to type in questions. I guess, Dr. Yanovic, let's stick with New York a little bit as well. You started to share a bit about your research in terms of New York City and the disparities in maternal mortality meaning deaths, and especially the issues with severe maternal morbidities or complications during birth, as well as death. deaths. Perhaps you could talk to us a little bit more about that and how some of those same drivers of disparities that you've seen make the challenges more difficult across different populations within this.
Sure, thanks. I think I first want to speak to the information gap that Dr. Wilcox spoke about. And I think knowing that there's these social determinants that are exacerbating already existing disparities, I think it's frustrating as well. I think that we have a lack of information still, months into the pandemic, really how these, how outcomes have been impacted. And sort of the lack of monitoring at the population level of what's even going on with pregnant and postpartum women. Now I know it's been, an unprecedented public health emergency, and health systems have had to scramble, but I think that it's still a bit shocking, the lack of information kind of guiding what is happening, and not just in terms of the effect of the pathogen on pregnancies, but sort of overall women's experiences with care, and their the sort of impact, the social and economic impacts that might be affecting their pregnancies or their postpartum period. So I think that I think that knowing, as we do, of what a large proportion of morbidity is due to these fundamental social determinants, we need to have better monitoring in place for public health emergencies of what women's experiences and needs are, so that we can address them more quickly.
Sure. Let's shift over to our Nepal lens again. Dr. Sapkota, you shared a bit about how the maternal and child healthcare system with which you're involved works, and there's this strong community health intervention based in combination and integrating into the care that's provided in hospitals. Could you tell us more about how that system and your integrated care has been impacted by COVID-19, and perhaps along with that, which groups within Nepal, how certain groups may be disproportionately impacted by the pandemic or the response to the pandemic as well?
Yeah, thank you. Just to kind of reiterate that prior to COVID-19, our program was focused both ends, facility, hospitals, and community level.
Mm-hmm.
The key thing here is because due to COVID-19, many things has been changed. The program at the community level was mainly focused on providing in-person, the conversation, care, and counseling to pregnant and postpartum women and mother with child under 2 years of age. We were running a group ANC program that collaborating with local health facility, and that was mainly around screening high-risk women and educating them around pregnancy and childbirth. But then due to this COVID-19 pandemic, the biggest challenge for us was due to this lockdown restrictions that was imposed since 24th of March, which is in place until today. I think only today that has been eased to some extent. Our community health workers are not able to make in-person household visits to pregnant women. They are not able to run group antenatal care, nor they could go and screen for high-risk disease conditions. On the other hand, because of this movement restrictions, women are not able to come for ANC appointments in the facility on time. There's a lot of stress and anxiety to pregnant women caused by COVID-19. They have a lot of fear of exposure and putting themselves more at risk, if they go out. There is a lot of anxiety at their end. Naya Health Nepal, what we did was like, because we knew we've been working in the districts where many vulnerable and marginalized women are living. So we adopted all our community health program to remote consultation approach. Since lockdown restrictions, our community health workers, they've been offering ANC counseling and consultation over the phone. I know it's not the same as having in-person visit and kind of like in face-to-face counseling, but that is something that would help them to kind of like, ventilate their anxieties, talk about what's going on, what they are feeling, and from our community health workers, and at least be able to check some of the high risk conditions and encourage them to go to the nearby health facilities. Challenges, in terms of reaching them over the phone is, especially talking about vulnerable and marginalized women, they do not have access to phone to even kind of talk over the phone with our community health workers. Since these districts are very remote districts, there is a lot of issues of network, connection. So that's still the challenge. But the other end, looking from healthcare, health facility perspective, even CSWs, community health workers, they encourage these pregnant women and mothers with sick child to visit health facility. They are very reluctant to go in there because it's for multiple reasons. They have a fear that they would not be attended by a health worker, or they're not even sure whether there will be a health worker present in the health facility because of all these movement restrictions. They would get exposed with COVID-19 cases because there will be other cases that will be coming to take services, or they have a fear that they would not receive enough attention when they visit the health facility. And then, I just want to kind of, quickly aspect a little bit around the national response.
Sure.
And these kind of, issues, stigma, anxiety, all these underlying kind of issues is very much kind of, familiar. And then to address that one at the national level, there have been quite a few guidelines that have been adopted, for this COVID context. For instance, there is a guideline for delivering maternal and child health during this pandemic. There has been a guidelines in terms of mobilizing community volunteers in the context of COVID-19 for prevention and education. Central to these guidance is continue, the guidelines saying is, the key thing is they are asking every health workers to continue providing basic and comprehensive emergency obstetric and newborn care with recommended measures around infection prevention and control, physical distancing, right use of PPE. But as we know, there has been some kind of, the structural challenges. These guidelines, there is a challenge in implementing these guidelines. Therefore, there's a lot of difficulties for pregnant women to seek quality care at this time.
Sure.
As a consequences, what happened was it's a very, very tragic news that we've been hearing every day in the newspaper. Since the lockdown started, Nepal has observed 24 maternal deaths in first 2 months of lockdown restrictions. Wow. That's huge as compared to 80 maternal deaths throughout the year last year. Yeah. Majority of deaths, is because they came to the health facility very late. It's a clear evidence of it's barriers around delays. This shows that women are not being able to come to health facilities on time, seeking care for danger signs and complications. And I think we all have already read it. There's early estimates published in Lancet last month only, that says around an additional 670 children could lose their lives every month in Nepal due to COVID pandemic if we don't take any urgent action, right? Right. But again, out of these 24 maternal deaths we've observed, there is a question of who has been affected the most, groups that are disproportionately impacted are those women. It's quite clear that these women are more from marginalized community, are marginalized by geography, marginalized by wealth and education. these women are like, the family of migrant workers. Some of these women are living with disabilities, and some of these women are prone to gender-based violence.
Yeah.
I mean, we discussed in the panel today that these groups are vulnerable prior to COVID context.
Yeah.
They are the one mostly affected from COVID pandemic, and they will continue to be impacted in the post-COVID-19 context if we don't step up and put up some measures to support them.
Sure.
Yeah, so as an organization, Health Nepal, we are focusing on, the first thing is like, we are working in the most marginalized and vulnerable communities. That's already in there. Every woman are vulnerable in there. But our focus is on identifying most vulnerable groups in our catchment areas. Our CSWs proactively reaching out to them and identifying them, following them, for care and counseling. They've been coordinating with the local community to offer some sorts of transportation facilities, ambulance, for example. They're constantly trying to make contacts, like, if they don't have access to mobile phone, then they try to kind of find a way to contact their neighbors, because, in Nepal, people live in a very close community, right? And that's most acceptable. They're constantly checking on them in terms of reminding them about danger signs, respond to their questions, anxieties, and encourage them to, visit local facilities where required. Top of that, I think we've also discussed in the panel about a lot of misconceptions around COVID-19. This is more around maternal and child health care, but COVID itself has a lot of kind of stigma for women, for healthcare workers. I just want to quote one incident that has recently happened, and it's all over the newspaper, that one pregnant woman who has been working in the front line in one of the COVID designated hospitals, she attended to one of the national level referral hospitals for bleeding, for antenatal pregnancy bleeding, but she was refused to be attended by the doctors in there. Because she's been working in in the front line in the COVID hospitals, and since they don't know whether she could be suspected, and there's no kind of guideline or workflow in terms of going through the test prior to attending any pregnant woman. So she was simply refused, and she's been denied for the dignified care in that hospital, and she had to go and seek care in the private hospital. So at this time, even frontline healthcare workers, especially if they are pregnant women, if they are pregnant, that's a kind of a stigma which we really can't stand on. Yeah, I'm going to stop here.
Sure, thank you. I think these are incredibly important examples and issues for us to think of in this way, the layers of marginalization and stigma, and how so much of this is creating a burden for pregnant women and babies and families around the world in this time during the pandemic as well. I want to turn to some of the questions we're receiving, and there are a few that kind of fit together in a particular way. We have a lot of research expertise on this panel, and also thinking from a systems level in terms of the issues involved. And at the same time, even as we talk about our research findings, I think we are united in agreement that actually, addressing and changing the health inequities of which we're talking, and addressing these issues of systemic racism, of the ways in which marginalization, discrimination, and stigma are contributing to these inequities are key. So this idea of translating research and findings into action. I wondered, so there are two questions, and I'm going to kind of combine it and address it to you, Dr. Wilcox, as a starting place. So as we think about these data that start to emerge, and you think, so speaking from your position as a hospital leader, as we consider Dr. Yanovic's research that talks about 1/3 of disparities for Black and Latina women being potentially due to hospital factors, as we hear, about how various hospitals may have higher maternal mortality rates and so on, how I guess I'd be curious to hear sort of how data are used to change, so to make changes within the hospital in this way, as well as things you might be able to comment on to interpret this a little further. And, when we think about hospital related factors in these data, what might that be related to in terms of their resources, insurance coverage issues, other biases that are operating, and so on. So kind of a practical example of how do we take some of these data that, that come out about the impact of hospitals and health systems, interpret it, and we hope, start to lead to actionable changes in that way. A big question, but you can start with that one.
For asking that question, that's a lot. I think there are a couple of things in there. The first is that New York City Department of Health received a large mayoral grant to address some of this in New York City, and they had a multi-pronged approach to deal with some hospitals in New York City that may not have had robust safety programs or may have had some worse outcomes. So they kind of just organized it according to different things. So the first was to implement their Maternal Quality Improvement Network, MHQIN, Maternal Hospital Quality Improvement Network. And there were 14 New York City hospitals in that network with a plan on their part to increase it to 21 hospitals in the next cohort. I'm not sure if the next cohort is coming, but really that dealt with embedding quality improvement programs within hospitals, and I believe they're having a paper come out soon about that work. The other part of it focused a lot on implicit and explicit bias and training and how to increase that awareness among providers across the city, and New York State is actually doing that as well. There were various training programs, various learning sessions. I will say that in these recent times of, watching the killing of Michael Floyd, right, it clearly is a much more pervasive problem than obviously maternal health care in New York City, right? I mean, this is a symptom of a much larger problem. And so that's what I meant earlier when I said that as someone who's been involved with this work from pretty much early days, it's sad, but it's also giving me hope that we can deal with it on a much larger issue, because for a while I have felt that if we continue just to focus on the providers, that's not really going to help solve our much larger structural racism problem. We have to deal with how budgets are allocated. We have to deal with hospital leadership, correct? I use the example, I'm the provider, I'm helping birth a baby, the room isn't clean. I'm not actually the one who cleans that. I need to call my COO and say, we need better environmental services. And so in many different forums, I've tried to enlarge the conversation and say, yes, providers are important. We're not the only point that you need to hit. There needs to be a much larger discussion. Quite frankly, in the state, maternal health care needs to be valued. It needs to be it needs to be something that is prioritized and receives resources, pretty much on a state and larger level. And so, but it has to start somewhere, and so we start on a local level, and then we try to push it up. In terms of other things that are taking on a much larger focus, in the COVID times, many hospitals, I would say most, were discharging mothers earlier. I've heard things, and also birthing centers. So I've heard information as quickly as 4 hours after birth to a day and a half after a vaginal delivery to 2 days for a C-section. Most of us were trying to get moms out of the hospital quickly. However, you cannot lose sight on postpartum complications, all of the things that can happen, not just depression, but also hypertensive issues, things like that. And so New York City Department of Health, I believe, is starting up a postpartum hotline to call all discharged moms from all hospitals, which will be very helpful on a local level. A lot of our facilities, certainly mine, has also tried to follow up with moms, not just those who are COVID positive, but all of our postpartum moms to make sure that they're okay. I'll just throw this in there, and that's not totally specific to our discussion today, but things that impact everyone else, access to grocery stores and food, access to, we want all our moms to breastfeed, but if they're not, formula, Pampers, disposable diapers, all of those things were in short supply, and people were told to shelter at home. So it really was quite difficult for some of our postpartum moms, especially if they did not have support people who were able to go out and get these things for them, to really try to navigate this stay-at-home COVID world in terms of getting the supplies that they needed. And I know that the Department of Health was very instrumental in securing some of these supplies, getting them to food banks and other locations where moms would have access to them. And those are just some of the problems that we've seen.
Absolutely, absolutely. Dr. Janovic, a question that I'll point to you from the Q&A box here, and I know we have time for just a few of these. In your research, are there ways that you're continuing to explore or dig into how some of these changes in care during the COVID period, in terms of just what Dr. Wilcox is describing, how we've tried to shift to telehealth and connections along these lines, but are you researching how those shifts may be affecting disparities at a population level right now? Uh-oh, I think Dr. Janovic, oh, there you are, sorry.
Sorry, I must be my connection. We're engaged in several projects. One is a survey called the VIBE survey, the Coronavirus Impact on Birth Equity among postpartum women in our healthcare system and in some of our affiliate hospitals, to try to understand what their experiences were during care, and whether they changed during the peak of the epidemic, as well as their levels of anxiety and stress and food insecurity.
Sure. Well, I'm afraid we lost you again for a minute there, but I think it is important to, as she's describing. Oh, I think we have you back. Sorry. I think I'll jump in as we're frozen for a second. I think what you both are pointing to in this, and what these questions are indicating, is such a critical role. The specific stories and individual cases that we see, whether it's a tragic maternal death, stories, like Amber Rose Isaac in New York, like these terrible stories of deaths that Dr. Sapkota is sharing from Nepal. Similarly, these murders that have our attention so clearly right now, in terms of George Floyd's death and Breonna Taylor's death. Well, these are, of course, each stories that are incredibly important for focusing our attention and our motivation, we also know that there's this broader set of data. I think the things just like the kind of research that Dr. Janovic is collecting that help to point everyone, as Dr. Wilcox was saying, to how this is a much bigger story than this, that the biases and the systems in place and the structures that are impacting this, as critical as those cases are, and as much as we want to focus on how we fix the specifics, that it's also important for that to go hand in hand with understanding the big picture of the forces and the history and the broken systems, or in such really wrong systems that are in place that are resulting in these kinds of cases along those lines. So how we shift, how research can help us shift that as well. I'm mindful of our time. I'd love to keep talking about this and answering more of these questions, but I'm afraid we do have to draw our time together to a close. I'd like to give each of our panelists the opportunity to share a final message, ideally perhaps one about hope as we look forward to this, in terms of how these challenges that you identify, the tragedies, the issues in our systems, what our data show us about the health inequities, how they might help to catalyze a more equitable health system as we move forward. Feel free in your closing though, if there's something you really want to make sure to add to, feel free to add that as well, especially as we do struggle with these challenges of limiting and putting an end to the COVID pandemic, trying to improve care for women, and how we address our systems and our national policies as part of that as well. Dr. Sapkota, I'll turn to you first, if you're willing to share your final message.
Yeah, thank you so much. I think the positive side in terms of the hope for us is, even though the numbers of deaths is very disturbing, I think civil society, that's kind of, is kind of a lobbying in terms of bringing attention of the government that, allocation of resources, all the resources just to COVID-19 is just not justifiable, right? And then there are a few positive steps in Nepal in terms of addressing these structural challenges, in terms of addressing the broader issue of equitable health care. Is one I can take here is Nepal has already moved towards decentralization, and this has empowered a lot of civil societies, empowered local governments to kind of, identify gaps in the system and address them, tailoring to their local needs. Because as we talked here, the context really matters. And I believe, this decentralization and a lot of movement from civil societies and, youth groups, who have been looking all these issues and, all these very horrifying deaths, they kind of, that brings some hope in terms of moving forward to catalyze a more equitable system. But what is a challenge, and we need to address, even having some hope, is we need to provide a lot of support to capacitate local leaders, especially those leading the health system, so that they understand how to address that gap. They may have a power to do it. They may have a kind of resources to do it, but in a way that really addresses the bottom line problem of this kind of issues around systematic challenges. I think there needs to be supported with a lot of technical skills around, or understanding, or a kind of a close dialogue around what is really happening in the ground and who are the most affected groups, in general. So my note is, I'm not kind of, the COVID has brought a lot of challenges to us. It's difficult for everybody. All the groups are directly and indirectly affected, but we have to acknowledge that women and children across all ages, they are most vulnerable, especially coming to pregnancy, childbirth, postpartum. That's something we cannot really compromise. Yeah, thank you.
Thank you. Thank you. Dr. Yanovic, I'm sorry that your internet or our internet in whatever way cut you off before, but perhaps some final words from you.
Sure, thanks. Sorry about the technical problems. Yes, so I guess it's just my hope that the tragic death of George Floyd, who it's kind of unleashed this really international reckoning with racism and the co-pandemic of racism and coronavirus, is going to lead to a transformative moment, you know, both for individuals and for systems, and that moving forward we can, you know, look at not only health systems but social policy systems as well, hand in hand, to try to restructure some of the inequities.
Thank you. And Dr. Wilcox, would you be willing to close us here with some last words from you?
Sure, I'll make this very short. I know time is of the essence. I am, again, going to just express my optimism that COVID has helped to hopefully expose the weaknesses in our system, as well as opportunities for us to really strengthen our current system, and you know, and that hopefully as the data comes forth and we study it and we look at it and we realize, you know, what the true effect of COVID-19 has been, that we address them, and hopefully with added vigor and resource. So
thank you.
I'm optimistic.
Great. Well, thank you so much to each of you, our panelists, for shining more light for us on these issues, the inequities faced by mothers and their babies in particular, and both locally and globally. And thank you to everyone who joined us today for this discussion to think about this a bit more. We do particularly hope that in these things that we are learning, that we want to commit to, you know, considering better together how we can move them forward into change in policy and our healthcare systems and in our communities globally as well. But thank you again. I really appreciate your time. We will be posting a recording of this webinar if anyone is interested in sharing it with colleagues and friends. It should be up on Mount Sinai's YouTube site it's typically there within 24 hours if you want to look for it. Our next Global Health and COVID webinar is planned for 2 weeks from now. Details will be forthcoming about the time, but the topic is going to be looking at police brutality as a global public health issue. So we hope that you'll continue to join us for these. And again, thank you to everyone for this discussion today. Bye.
Thank you for having me. Bye-bye.
Thank you very much.
Thank you.
Thanks.